Stage 2 of the upper to lower lid tarsoconjunctival flap, or Hughes flap procedure, involves division of the flap. Traditionally, this used to be done about 6 weeks after stage 1, but in fact the flap can be divided as early as a week after the primary surgery. When the flap is fashioned, the upper lid retractors are pulled inferiorly, which is similar to the plication that is done in a posterior ptosis surgery procedure. Therefore, in stage 2, it is advisable to release the retractors to minimize the risk of post-operative lid retraction. A 4/0 silk traction suture is inserted into the upper lid grey line. The plane between the Muller's muscle and levator must be identified, or if only a conjunctival flap has been brought down, then the plane between conjunctiva and Muller's must be identified. If the flap is divided early, the plane can often be found with blunt dissection, as you see here. But sometimes a few small snips with spring scissors are required. The plane can then be continued superiorly, relatively easily with blunt dissection. There is no specific superior limit of dissection. It just has to be far enough to allow the retractors to return to their normal location. However, the white line on the posterior surface of the folded levator, which probably represents the point at which muscle becomes aponeurosis and levator and Muller's fuse, is a good target. The flap is now divided. Some people advocate dividing it with the skin slightly recessed in order to reduce the likelihood of skin overgrowth onto the lid margin. Conversely, others recommend dividing with the skin edge advanced, as this may reduce the likelihood of the thickened red lid margin that can occur in the first few months after division. In view of this disparity of opinions, we tend to cut the flap horizontally or with a slight skin recession.